surgery.
Cannot move properly. Okay, so this is my presentation. So this is something that we discussed a lot a few years back, but nowadays it's not very common that you have this pro and contra for robotic and open surgery. In most countries, not in Germany, but in most other countries, there are actually done more prostates in the Western world, so it depends on where you are, of course. But if you go to the US, you go to many of the European countries now, there are more robotic prostatectomies performed than open. But that every country has its own problem when you start discussing robots, because they are depending on the healthcare system. So why would you like to use the robot? I think you like to use it because it's minimal invasive, basically. So that's the first thing. So it's a minimal invasive operation, and for many, many operations, not only radical prostatectomy, but in general surgery and in gynecological surgery and so on, it is better to do minimal invasive operation if you can. So you will have less bleeding, less post-operative pain, shorter hospital stay, quicker return to daily activity. This is something which is true for almost all types of surgery. Whether the surgical outcome is better is much more controversial, and I'll come back to that. And there are some other things which might be interesting for some patients, not mostly for prostate cancer patients, but cosmetic outcomes and things like that. The problem when you think about minimal invasive surgery, when you do a complex operation, is that conventional laparoscopy is very difficult to learn. You can learn it, but you have to spend a lot of time and a lot of effort and do many patients. And this is Jens Rastweiler's learning curve for laparoscopic prostatectomy. And this is my learning curve for robotic prostatectomy. You see that's a huge difference. And this is not only mine, this is the first 4 surgeons who started at Karolinska, and you see that all of them basically follow the same curve. So it's easier to learn robotic than conventional laparoscopic surgery. And this has been studied a lot. There's many tests in the beginning that was studying, the proficiency, efficiency of movement and so on. And I think that now we have level 1 with evidence that it's easier to learn robotic minimal invasive surgery than conventional laparoscopic minimal invasive surgery. But there is no difference in the learning curve with open and robot. I mean, there is no scientific evidence that there is a very different learning curve. But if you want to go minimal invasive, probably it's much easier to go through the robot than to go through conventional laparoscopic. Perioperative outcomes. This is something that's also been studied in a lot of studies, and this was one of the first areas that was studied when the robot came. And there are several meta-analyses that have looked into this. This is, for instance, transfusion rate, and you see that you have around 20% here, the meta-analysis in the open, and 1.5% in the robotic group. This is from a paper this is a meta-analysis with over 100,000 patients. We went through all the papers on robotic, open and laparoscopic prostatectomy from 2002 to 2008. It's more than 100,000 patients. And you can see that the estimated blood loss is much lower in robotics, transfusion rate lower in robotics, length of stay in the hospital is lower in robotics, whether it's inside the United States or outside the United States. So this is very consistent finding in the literature. Something which is less consistent is when you look at complications. So if you look at complications, perioperative and intraoperative, this is from the same meta-analysis then based on 100,000 patients, and a lot of studies showing that the complications, intraoperative and perioperative complications, seems to be lower in robotic surgery compared to open. If you look at more long-term complications, it's much more difficult. There are some studies show that there are no difference. Some studies show that there is less complications after robotic surgery. In our series at Karolinska, we had much less complications, but that's partly because we were lousy open surgeons. So then if you change your program and you really focus on doing something good, and because what we did, we were much more focused on cystectomy before, now we refocused to prostatectomy, and we became much better. And that was partly because we switched to robot, but I think it was also because we changed the focus of the program, basically. Anyhow, there is no studies showing that you have much more complications after robotic surgery. There are some showing that you are better with the robot, and some showing that you are basically similar. 1 year ago, now it's almost 2 years ago, there was a consensus panel looking into robotic radical prostatectomy. Some of you in the room were at this meeting in Pasadena, and they were looking into different aspects of robotic surgery and comparing to open surgery and also laparoscopic. But here we focus on the comparison between open and robot. And you look at the perioperative outcomes and complications, I would say that they had the same conclusion then, that perioperative outcomes, bleeding, transfusions on favors robotic surgery, complications, much more difficult to say that there is a difference. So I think that we now have level 1 evidence that there are in some ways, the robot is superior to open in this perioperative time or period. Oncological outcome, not a lot of difference, and probably you should not expect. You try to find the same surgical plane, and you will not. I think the robot is not the way to cure more patients. It's a way to maybe do another type of surgery, but the oncological outcome doesn't seem to be worse than open surgery. In the beginning, there was a lot of discussion whether you have more positive margins and more biochemical recurrence and so on, but there is no evidence that to support this. The evidence that is maybe the other way around. So if you look at here, it's a positive margin rate overall in the Pasadena consensus, basically similar, favors robotic just as little, but it's not statistically significant. This is from our meta-analysis. Tavares, the first name of this, published in European Urology, seems to overall favor actually robotic, but when you adjust for difference in Gleason and stage migration and times and things, the difference is very small and probably it's not significant. And I would say that the oncological outcome is very similar between robotic and open surgery. And we think about the functional outcome then. So look at the continence. So this is something which is more controversial, I think. Here in the Pasadena, they looked into studies only which had looked into robotic and open at the same time. So only papers where they had both techniques in the same papers were used. And there they found that there was a significant difference favoring robotic surgery. I'm not sure that this is the case, but it's definitely not worse to the robotic surgery as far as continence. If you look at the potency rate, this is also from the Pasadena, this clearly favors robotic surgery. And I think that this is the main, if there is a difference between robotic surgery and open surgery, is that you can do a better nerve spare. You see better what you do, you can go in the nice plane, and you seem to be able to do this with similar margin rate as in open surgery. For us, definitely it was a big improvement. I think that in most series you will see the same thing. So here the conclusion is from this Pasadena consensus meeting that it seems like it favors robotic surgery over open surgery, but there is no really good randomized trial to study this, so you cannot say for sure that this is the case. Another issue that's often discussed when you discuss open and robotics is the cost issue, and this is going to be very different in different countries. So depending on the economical situation and the healthcare system, you will have very different outcomes here when you think about the cost. So for the hospital, it's a bad deal to buy a robot because it costs a lot of money and every procedure costs money. So if you're head of a department in Germany and you have to pay for your own robot and you cannot get more money out of the patient, you will have a problem to finance the system. If you have, like I'm living in Sweden, where the same body pays for all the healthcare, which means that the same money comes to buy the robot that pays for the patient's recovery afterwards. And we can make money in Sweden by doing robotics because we have much shorter length of stay. So nowadays in Karolinska we do only robotic cases, and almost all patients, not all, but most patients will go home the day after surgery. So we can do 2 or 3 times as many patients in the same amount of beds. So suddenly you can make some money out of the system. And you can also see that the healthcare system, if they are paying for the time it takes to go back to work, you'll see also that there's a huge difference. This was a study done in Sweden by a group which is open surgery, and they wanted to prove basically that was not such a big difference. But it turned out that 50% of the patients were back to work in the open group after 49 days, and in the robotic group they were back to work after 11 days. So that's a huge difference. But as a head of department, you don't get any of this money, but the healthcare system will get some of the money for this. So economically, it's very complex to calculate. But my main message is that all of these things are good, but what drives me to do robotic surgery is the future of surgery. Because I think that if you are running a department where you want to be part of the future of surgery, you have to see when the future is changing. And here you see, I don't know if there anybody from Denmark here? No one, they're not skiing in Denmark, so I guess they're not here. This is the Graubalemannen, so he's one of these men that they found. He's more than 2,000 years old, and if you look at this guy, his hand looks like this. So it's perfectly preserved, and it looks exactly like your hand now after 2,000 years. And I think that the development in open surgery is not going to be very strong, because you will not be able to develop this a lot. But in the robotic surgery, a lot of things is going to happen, of course. One of the things that's happening is also single-site surgery, and you can discuss whether it's good or bad, but I'm convinced that we are going to do more and more surgery with single sites. And the robots that are going to be developed are going to be different. One of the things is that it's very nice with the single site right now, because you can cross the robotic arms, and you can just push a button, and you can run the right arm with your left arm, and the left with the right, so you don't have to, you know, think about crossing the arms and so on. You just run the right with your left, and it's totally natural. So there will be some benefits in robotic surgery, I think, as far as development is concerned. And this is the platform now. I don't know if you have seen the robotic platform for single surgery. It's useless, basically, because the instruments are not movable in the right now. You don't have a wristed function. So right now it's not good, but I'm convinced, and I know that the next platform is going to be much better for single-site surgery. You have the mentoring network. I think one of the major aspects is how to educate and learn surgery. And I think that this is, for open surgery, it's very difficult to know. I mean, you have to be almost at the patient side and look into the patient and have your hands in the patient to really learn how to do open surgery. But when you do robotic surgery, you can have the same image as the surgeon, and thousands of doctors can look at the same operation and see it exactly the same way. Here, this is Jim Porter mentoring a patient, or a surgeon rather, and so he can sort of be on the computer and be live and comment what the surgeon is doing in another area, and he can even make drawings on the screen to direct where you should go, where you should cut, and so on. This is a nerve sparing, so you see now he can actually move, and I think he's talking to the surgeon real time and can get the information across. So this is things that you can do now more easily, I think, with the robot than you can. And you will also have a lot of developments of new instruments. So right now still this is a technique which is just like 10 years old, and I'm convinced that in another 10 years it will be developing a lot, and in another 10 years and so on it will develop. So I think that we'll have to see this development, and here you can see the image fusion, which means that you can lay onto your operating field images of tumors, blood vessels, or whatever you want. So this is also something that's going to happen in the future, and this was, of course, something very intriguing in the beginning, is that surgeons don't have to fly around anymore. You can sit in one place and the patient will be in another place. This is not really something that is used at this point, but I'm convinced that in the future you will be able to use it. And there is a lot of new robotic platforms developed right now. There is Italian, German, Korean, Japanese, and American, and so on, Canadian, and so there are a lot of different things coming on. So I think that right now then the perioperative outcomes clearly favor robotic surgery. Oncological outcomes are fairly equal. Potency outcomes, I believe most of them favors robotic surgery. Hospital economy favors open. General healthcare economy is more difficult to understand if it favors open or robotic. Continence, I think, is a question mark, but I'm clear that future development favors robotic surgery. Okay, thank you.
Thank you very much. I think we should start with Peter and then the other Peter, and then discuss it together. Thank you very much, Peter. That was an excellent talk.
Well, Peter